Let's jump right into the Step 2 CK and Step 3 rapid review covering environmental emergencies and toxic inhalations. We're zeroing in on high-yield ED stabilization algorithms for heat and cold injuries, drowning, and toxic exposures, keeping our focus strictly on next best step management logic. Section 1. Heat Illness Syndromes. Whenever you're managing hyperthermia, you've got to evaluate two key things: core temperature and mental status. With heat exhaustion, you'll see a temperature that's usually 40 degrees Celsius or lower, and crucially, a completely normal mental status. The patient might present with profuse sweating, weakness, dizziness, and tachycardia. Your first-line management here is simple: cooling and oral salt-containing fluids. You only step up to IV fluids if there's severe dehydration or if they just can't tolerate anything by mouth. Now, here is your critical exam branch point between heat exhaustion and heat stroke: central nervous system dysfunction. If you have a core temperature of 40 Celsius or higher and it's accompanied by altered mental status, confusion, a seizure, or a coma, you are dealing with heat stroke, period. This is an absolute emergency requiring immediate ABC stabilization and rapid cooling. How you cool them down actually depends on the etiology. Exertional heat stroke typically hits young, healthy individuals after strenuous activity, like athletes. The preferred next best step for them is rapid ice water immersion. But classic, non-exertional heat stroke often affects elderly patients who have impaired thermoregulation or certain medication exposures. You don't want to use ice baths here because they're poorly tolerated. Instead, the indicated next best step is evaporative cooling using lukewarm water and fans. Watch out for this classic exam trap. Antipyretics like acetaminophen and muscle relaxants like dantrolene are definitely not indicated for heat stroke management. Remember, heat stroke is an environmental failure of thermoregulation, not a hypothalamic set point shift like a fever. Antipyretics won't do a thing to help and can actually exacerbate hepatic or renal injury. Section 2. Hypothermia Stabilization. Moving on to cold exposures. Mild hypothermia sits between 32 and 35 degrees Celsius. These patients present with tachycardia, tachypnea, ataxia, dysarthria, and active shivering. Once the temperature drops below 32 degrees, they hit moderate hypothermia. The shivering completely stops, and you'll start seeing bradycardia, hypoventilation, and lethargy. Severe hypothermia kicks in below 28 degrees, presenting with coma, cardiovascular collapse, and a massive risk of ventricular arrhythmias. Here's another exam trap. In moderate to severe hypothermia, patients develop profound bradycardia. But here's the catch. This bradycardia improves with rewarming, not with atropine or cardiac pacing. Also, make sure to handle these patients extremely gently. The hypothermic myocardium is highly irritable, and rough movement can easily provoke life-threatening ventricular arrhythmias. Rewarming has a very specific stepwise approach based on severity. Step 1 for mild cases is passive external warming. Just remove any wet clothing and apply warm blankets. Step 2 for moderate cases steps it up to active external warming using heating pads or warm baths. And Step 3 for severe comatose cases requires active internal rewarming. This means using warmed pleural or peritoneal irrigation and warmed humidified oxygen. Section 3. Frostbite Management. Keep in mind that systemic hypothermia must always be stabilized before you worry about local frostbite. Frostbite starts with superficial pallor and anesthesia, and then progresses to blistering, eschar formation, and deep tissue necrosis. This is driven by ice crystal formation and microvascular thrombosis. Your initial baseline management for tissue salvage is rapid rewarming in a warm water bath set strictly between 37 and 39 degrees Celsius. Right after rapid rewarming, you need to provide analgesia and dedicated wound care. If the extremity stays cold and ischemic, you have to assess for deep thrombosis using advanced imaging like angiography or a technetium 99M scan. If you identify thrombosis in a severe limb-threatening presentation, that's when you consider thrombolysis. A couple of absolute rules here. Do not rewarm frostbitten tissue if there's any risk of it refreezing before definitive care. A freeze-thaw-freeze cycle completely destroys tissue. Also, you must delay amputation. Tissue actually needs weeks to months to fully demarcate, so avoid early surgical intervention unless you're absolutely forced to act because of infection or sepsis. Section 4. Drowning Resuscitation. Let's transition to drowning. Hypoxia is the primary driver of morbidity here, making early rescue breathing absolutely critical. In the ED, symptomatic patients need oxygenation, continuous monitoring, a chest X-ray, an ABG, and strict observation for ARDS. But don't let asymptomatic patients go right away. They must be observed for at least 8 hours with continuous monitoring and a repeat chest x-ray before discharge to rule out delayed pulmonary edema. On the exam, you need to recognize the poor prognostic indicators for survival and neurologic recovery in drowning scenarios. These include a submersion time greater than 5 minutes, delayed initiation of CPR, prolonged resuscitative efforts, age greater than 14 years, and a severe metabolic acidosis with an arterial blood pH below 7.1. Section 5. Smoke and toxic inhalation. Shifting to fires and enclosed space exposures. You have to prioritize airway preservation and immediately anticipate toxic gas exposures. Smoke exposure in an enclosed space is a massive red flag for concomitant carbon monoxide and cyanoid poisoning. Your immediate next best step is the empiric application of 100% high-flow oxygen to actively displace carbon monoxide from hemoglobin. Thermal injury brings a huge risk of rapid, progressive airway edema. You need to secure the airway via endotracheal intubation early if you spot any of these signs: oropharyngeal blistering, stridor, retractions, facial burns, singed nasal hair, or carbonaceous sputum. You have to be proactive and intubate before the swelling makes the procedure physically impossible. With carbon monoxide poisoning, the patient typically presents with headache, syncope, and potentially that classic cherry red skin. Keep in mind, standard pulse oximetry is completely unreliable here because it can't differentiate carboxyhemoglobin from normal oxyhemoglobin. It'll often falsely read 100% saturation. To get the diagnosis, you have to run an ABG to directly measure the carboxyhemoglobin level. Carbon monoxide and cyanide toxicity frequently show up together in fire victims. You treat the CO poisoning with 100% oxygen and escalate to hyperbaric oxygen if there are severe neurologic signs or ischemia. Cyanide toxicity usually comes from burning plastics, and it inhibits oxidative phosphorylation, giving you an elevated lactate and a severe anion gap metabolic acidosis. For smoke inhalation victims, you treat empirically for cyanide using hydroxycobalamin or sodium thiosulfate to prevent cardiorespiratory arrest. And just to round out our environmental emergencies, if you're dealing with electrical injuries, administer aggressive non-potassium IV fluids and monitor closely for rhabdomyolysis and arrhythmias. Finally, for envenomations like snake bites, immobilize the limb, observe coagulation studies closely, and only pull out the antivenom for unstable vitals, rapid local progression, or systemic toxicity. Stick to these algorithms, and you'll be well prepared for these scenarios on exam day.